I am going to talk to you guys today about management of traumatic nerve injuries, and I am presenting this here from our Penn Nerve Center at Presbyterian Hospital, which I'll talk a little bit about. So I'm going to start very briefly with a review of the general anatomies, particularly of the brachial plexus, and then we'll talk about some case examples and some of the work we're doing at Penn related to our spinal cord injury clinical trial, and then lastly touch base on our new Penn Nerve Center. So as you all probably already know, the brachial plexus is a network of nerves that originates from the cervical and upper thoracic nerve roots. The nerves then combine to form the cords and divisions and then the distal nerves. I'll be talking about a variety of different injuries that occur at any one particular area at the level of the plexus, and you'll see that it's anatomically for us very, very important to isolate where along the plexus a nerve injury may lie. The most common types of trauma that we see are either open or closed trauma. Closed tends to be much more common, and you can see in this schematic the types of injuries that result in stretching or avulsion of the nerve roots off the spinal cord generally are due to both rotational and direct impact at the level of the cranial cervical angle. So you can see here how these nerves may be injured with any of these rotational forces. So when we think about the trauma that a patient may have due to brachial plexus injury, again, sort of compartmentalizing these types of injuries as open versus closed helps us determine what we're going to do for treatment because it very much varies. So when we think about an open injury, we think about, a laceration or a transection of any of the neural elements within the brachial plexus. And these are treated differently based on how that laceration occurs. So when we think about a sharp injury where we have a sharp, stab wound, knife wound to the nerve, we know that these nerves are divided sharply, and these tend to be our most sort of hyperacute injuries where we want to treat those relatively acutely, ideally within 3 days. And these also do have the best chance for improvement in function following direct repair. In contrast to that, you can get a sort of blunt or ragged laceration of the neural elements. And in this case, often patients are taken to the OR for other reasons, and surgeons will often tack the nerves or apply a suture for identification of the nerve to the adjacent plane so that we could then go in there with a secondary repair around 3 weeks after surgery. And the reason you don't want to repair these injuries acutely is that, with a ragged and blunt type of laceration, we know that there is trauma right at the site of the jagged edge and distal and proximal to that. So we don't want to repair an end-to-end nerve that is not healthy. And so giving it that 3 weeks of time allows for that injury to sort of declare itself, or the sort of distance of the nerve to declare itself, and then we're able to sort of bring a patient back to the operating room and actually repair healthy tissue to healthy tissue after we cut out the scarred component of the nerve. So closed injury is by far and away the more common injury that we see. And these are lesions in continuity from, as I mentioned, stretch or contusion of the nerve. And there's a variety of different mechanisms. Most commonly, we see this in high velocity injuries, such as motorcycle and motor vehicle accidents, in which we get a high velocity stretch or contusion of the nerve. But these can also include compression neuropathies, ischemic neuropathy, injury, electrical or injection, or even iatrogenic injury, which we see as well. So these patients often require a variety of diagnostic testing before we make a decision as to whether or not we're going to operate. And then secondly, also think about the timing related to when we are going to operate. So often we are looking at things like the clinical exam. The history and physical are extremely important in peripheral nerve surgery, and the timing of incident and what that clinical exam looks like over time is critical to understand whether or not there is regeneration happening or not happening. And we use a variety of adjuncts, including EMG studies. We use imaging studies such as ultrasonography, CT myelogram, MR, also to assess for whether nerves are in continuity or not. And then again, we're really thinking about, is there active regeneration happening spontaneously, in which case we want to continue to allow that to happen until it plateaus. Or if there's no evidence of recovery, that's where we want to think about exploration and reconstructive procedures. So usually this is on the order of around, at the very earliest, 3 months out from injury, more commonly somewhere in the 3 to 6 month range after a closed injury. And just to sort of remind you about, the physiologic basis of this, when we think of nerve injury, you can have kind of the more mild type of nerve injury, which includes neuropraxia, where you're disrupting microtubules and the myelin sheath, but these tend to recover spontaneously. In axonotomesis, we're actually disrupting the axon fibers. These have more of a variable course in terms of recovery and regeneration. And these are the ones that we're often, sort of doing the serial examinations and electro diagnostic studies in order to determine time point of operating. And then lastly, a neurotomesis injury, this is where you have a full transection of the nerve, and those often always require surgery because they have no chance of spontaneous recovery. But as you can see, we're constantly thinking about, number one, time, because time is nerve, right? So the longer an injury persists, the more sort of Wöhlerian degeneration occurs at the level of the nerve, the more there is end organ, in this case, the muscle, becomes more atrophic and not suitable for reinnervation. So we're constantly balancing sort of the level of injury, the severity of the injury, and what, if any, regeneration is happening in order to determine the appropriate time point of surgical intervention. So in terms of surgical approaches, we often think of a couple of different options for accessing the brachial plexus. By far and away, the major workhorse is our supraclavicular approach to the plexus, and that gives us a good view of the spinal nerves that you can see here, as well as the trunks. And often, we can follow the trunks distally until we can see the start of the divisions, but then we're usually limited by the clavicle. And so often we'll combine this approach with an infraclavicular approach, and which we're looking at the cords and the distal nerves at the level below the clavicle at the deltopectoral groove. There's also a posterior subscapular approach and the transaxillary, or even a combined approach. These we very rarely use, but in general, we're thinking about the posterior triangle of the neck in terms of our exploration. And you can see here, this is a cadaveric dissection, which clearly identifies the neural elements of the nerves and the trunks at the level of the supraclavicular plexus. And then this is an infraclavicular dissection in which we're looking at the level of the cords and the distal nerves. So when we think about the types of injuries, I'm going to give you a couple of examples and then also some cases and try to illustrate, the kind of decision-making we take for managing some of these patients with nerve injuries. So this is a patient that had a stab wound to the neck. He underwent a exploration of the neck and chest. His exam was notable for shoulder abduction weakness, external rotation weakness, elbow flexion and extension weakness. He had some wrist movement, but it was weak but present. Numb shoulder, arm and radial forearm into thumb and index finger. So often the exam really guides us to, where can the level of this injury be? And you can see that, he has weakness in shoulder abduction, external rotation, elbow flexion, extension. So we know his upper trunk has to be involved, and the sensory distribution gives us some information about probably the middle trunk also being involved here. So he was ultimately taken for surgery, where you can see this is the upper trunk, middle trunk that you can see here. This is supraclavicular brachial plexus dissection, and you can see that there is injury to the upper and middle trunk. We're able to resect any scarred elements of the plexus and then directly repair end-to-end those neural elements. So in contrast, a Cole's injury would be, this elderly lady falls on the left shoulder, transient dislocation, but then has weakness, deltoid triceps, brachioradialis, wrist and finger extensors. So again, that exam is critical for us to start to think about and localize where this injury can be. She can perform shoulder abduction up to 20 degrees, which usually tells us that supraspinatus is intact and probably the part of the C5 elements are still intact. And then also able to flex at the elbow and wrist and hand intrinsics. Again, sort of pointing to the fact that this looks more like a posterior cord injury. You can see here there's sensory loss in the lateral and posterior arm and dorsal forearms, which kind of fits with the posterior trunk. So you can see in this type of approach, we would take an infraclavicular approach to the plexus, in which we're dissecting out the neural elements at the level of the cords and distal nerves. So proximal is up here. This is where the clavicle would be. And you can see here we encircle the neural elements with vessel loops. And you can have, here you have the radial nerve and the axillary nerve coming off the posterior cord. And we're able to perform intraoperative nerve action potentials to identify whether or not there is active nerve conduction across that element of the nerve. And in general, we utilize that in determining whether or not to just neuralize the nerve versus to resect a scarred neuroma within the nerve. So if there is evidence of a nerve action potential, often we just perform external neurolysis, as in this case, which tells us that there is active electrical signal going from proximal to distal, which suggests that the patient should have spontaneous regeneration, versus if there's no evidence of active nerve potential, we often will then transect the nerve, identify scarred elements of the nerve, resect the scar, which I'll have another example of, and then coact the two ends. So this is another example of a 28-year-old male who came in with multiple gunshot wounds. Often these patients have multiple other injuries that you can see in this gentleman. Ultimately, he was noted to have weakness, specifically in his biceps, pronator, FCR, APB, and opponents. And so again, we're thinking about, where along the pathway of the plexus could this patient be having an injury? And so we're thinking about where we would access the plexus. That helps us define where we're going to, whether or not we're going to do a supraclavicular only or a supra and infraclavicular exploration. And we know from his original operation that they saw some elements of nerve damage. And so our team was consulted. Here you can see his bullet fragments. So when we think about gunshot wounds, they're a little bit different than other types of open or closed injuries. So we often treat them a little bit more like a closed nerve injury because we know that there is more injury to the nerve than what happens right at time zero. So many of these patients, even if they have neuropraxic injuries at the time of the gunshot wound, they do tend to recover spontaneously. So we often follow these patients very closely with clinical exams as well as electrodiagnostic studies. Often, if we know from direct inspection with with an original surgery for other traumatic injuries that there is nerve disruption, then we tend to operate on those patients sooner rather than later. And so this is a patient that ended up having contusion to the musculocutaneous nerve. That's why he had weakness in his biceps. And we also know that the median nerve is disrupted. That was evident on clinical exam from his weakness in opponents. And so this is a case where we utilize sural nerve grafts to bridge the defect. In this case, we're doing cable nerve grafts, which utilize multiple segments of the sural nerve to then reconstruct the lateral and medial cords down to the median nerve. These patients who undergo nerve grafting, we tend to require them to be in some form of immobilization. In this case, we often use a soft collar and a sling for up to 3 weeks. And that allows for healing of the microneurosurgical repair and avoid any disruption of the suture coaptation. Following that, it's critical that these patients undergo aggressive physical therapy, and then we tend to follow them clinically with exams over the next 24 months. So this is another example of actually a injury to the nerve from an iatrogenic injury. This is a patient who underwent a left lymph node biopsy, and following the procedure had severe burning in the right neck and weakness in shoulder shrug. And this patient originally started physical therapy, didn't have benefit, but continued to notice a decline in shoulder function, and ultimately developed atrophy of the right trap and weakness in shoulder shrug and scapular winging. She underwent a series of studies which demonstrated that EMG ultimately showed no voluntary units in the trap and abnormal nerve conduction velocity. So this is a patient who we explored 8 months after injury. In this case, again, we're doing a similar approach at the level of the supraclavicular plexus, but here we're isolating and identifying the spinal accessory nerve, which is the nerve that was iatrogenically injured. And here we're able to identify the nerve, identify both the proximal and distal segment of it, resect any neuroma that has developed along the ends of the nerve, and then coapt the nerve together. Primary epineural suture repair tends to be the best option for injuries like this, as long as the nerve can be coapted without tension. So that is critical to the nerve regeneration. There's another example of a 27-year-old man who had a severe right knee injury while playing football. This resulted in a complete foot drop. He ended up having reconstructive knee surgery, and there was noted an evidence of contusion and injury to the common perineal nerve, which is critical in allowing for dorsiflexion of the foot. And then he was ultimately referred to neurosurgery, and EMG did identify that the nerve was completely disrupted and there was no evidence of nerve regeneration. So this is where we absolutely recommend surgical exploration of the nerve to identify if there is neuroma in continuity. So you can see here his tibial nerve is up here, and then we're following the common perineal nerve, which is the nerve that's important for dorsiflexion. And he has a large large segment neuroma within the common peroneal nerve, which is limiting axonal regeneration. And so we're able to isolate that. And then this is a good example of utilizing and relying on intraoperative nerve action potential to identify if there's any active regeneration across the nerve. And in this case, there was not. And so we then resect and isolate out the scarred component of the nerve, which you can see here on axial section of the nerve, where we have loss of that normal fascicular anatomy. And so we go ahead and resect until we find, kind of healthy appearing fascicles, which in this case is a pretty long segment defect in this patient. And so we go ahead and perform a sural nerve harvest, in which we utilize our sural nerve grafts in order to create a cable graft across the proximal and distal end. And we primary suture repair and then apply fibrin glue, which you can see here, over the sutured sites. And so then it is, we wait and allow for nerve regeneration to occur, which is a very slow process. It is on the order of 1 millimeter a day or an inch a month is the way to think about it. And so again, remember, that's nerve regeneration across the site of where we believe primary regeneration occurs at the proximal stump, and then going all the way down to the distal target. So again, as I mentioned before, these patients are immobilized relatively for 3 weeks to allow for that microsurgical repair to heal. And then ultimately we allow for a gentle range of motion. And actually, this is where I would highlight that the therapy post-op is really critical in order to promote that regeneration. And we follow these patients serially every couple of months. Unfortunately, I'm not going to be able to show you this nice video of this patient's dorsiflexion coming back maybe at the end of the talk if I still have time. So nerve transfers. Nerve transfers are another type of surgical repair, and these are really game changers for us in the nerve surgery world, because they really change the way we kind of think about managing these injuries. So the idea is determining whether or not there's an expendable donor nerve or fascicle that can be redirected to a distal nerve stump. And so the idea is we're sort of bypassing the actual site of injury by utilizing a healthy, normal, redundant nerve to sort of fulfill the function of the damaged nerve. And we think of this as donor distal. So what this is the mantra we use when we're doing these surgeries, because we want to dissect out that donor nerve as distally as possible and then bring it to the damaged nerve. And that shortens that regenerative distance. As I just mentioned, regeneration happens very, very slowly. So if we could reduce sort of the distance of that, that should, in theory, improve our regenerative potential. And so we see that in these nerve transfers, which I'll show you examples of. And then the other advantage is that since we're repairing or doing that transfer distally at the site of the end organ, we have less of a likelihood of having the regenerative axons get misdirected or to lose their regenerative potential in that kind of long wait for 1 millimeter a day of regeneration. So this was first described by Chris Oberlin, and the most common nerve transfer that we perform is called the Oberlin Procedure. It's where we have a patient that has weakness in the bicep, and this is often the case in patients that have upper trunk injuries at C5 or C6, where they lose the ability to flex at the elbow. And so what we do is utilize a redundant source of nerve. In this case, we utilize the ulnar nerve fascicle and bring it over to the musculocutaneous nerve. Now, the ulnar nerve is a very important nerve for hand function. It also provides some wrist flexion, which is a redundant function. So other nerves are able to provide that function. And in general, when we're doing a nerve transfer, we're doing this under microsurgical repair, where we're actually opening up that ulnar nerve, identifying many of these fascicles and directly stimulating these fascicles. And so we're able to identify which fascicle sort of provides more, wrist flexion, for example, as opposed to intrinsic hand function. And so we're able to identify the donor that way, and then neuralize that donor internally, and then bring it over to the musculocutaneous nerve, which we cut at the level of just before it enters the biceps muscle. And so again, we're kind of shortening the distance for the regenerative potential of this ulnar nerve to regenerate right directly into that biceps muscle. So this is a very good nerve transfer. It's our workhorse transfer for patients that have elbow flexion weakness. It works very, very well. And, this is, I would say that nowadays with nerve injuries, even traumatic closed brachial plexus injuries, many centers think about going directly to nerve transfers if, sort of the timing is appropriate, and avoiding kind of the scarred up plexus. Now that's debatable, I would say, because nerve grafting is still, there's still certainly a place for nerve grafting. And, really without exploration of the plexus, it's not entirely clear which elements of the plexus are functional or not functional electrically at the time of surgery. So often most folks would do an brachial plexus exploration and then usually utilize a nerve transfer in addition to a direct exploration once you've kind of identified that, C5, for example, is avulsed. Other common nerve transfers, this is another very good nerve transfer that we commonly do, utilizing the distal spinal accessory nerve to the suprascapular nerve. So spinal accessory nerve is a cranial nerve. It is often not affected in a plexus injury. So it is a very good extraplexal donor for these patients. Suprascapular nerve is an important nerve for giving you some initial shoulder abduction as well as external rotation. And so it's very important for shoulder stabilization, and many patients with an upper trunk injury will lose this function. And so what we're able to do is co-opt that spinal accessory nerve from a supraclavicular approach, or even from a posterior approach has been described, where we're able to co-opt that distal spinal accessory nerve directly to the suprascapular nerve, reduce that distance for regeneration directly to the supraspinatus and infraspinatus muscle. And this gives patients the ability to shoulder abduct. Another great transfer is what we call the Samsa transfer by Professor Samsak in Thailand. This is a transfer that we utilize the radial nerve, which is functional in these patients, and co-opt that to the axillary nerve, which is not functional. So these are patients that have preserved elbow extension and have nice strong elbow extension, but poor shoulder abduction. And so we're able to transfer a single fascicle of the radial nerve, which has multiple fascicles going to the triceps head, and take one of those fascicles and co-opt it directly to the axillary nerve and get back some deltoid function. So I'm just going to touch briefly on our multi-center spinal cord injury trial. So as you can imagine, with the advent and popularity of nerve transfers, we have thought about nerve transfers for a variety of other indications besides just peripheral nerve injury. So in particular, spinal cord injury has been an area under investigation. We at Penn are part of a multi-center clinical trial that's run by our colleagues at WashU, in which we are enrolling patients for nerve transfer for spinal cord injury. So just to give you some background, we know that spinal cord injury can result in a profound impact on quality of life, especially as it relates to upper extremity and hand function. Traditionally, these patients have required tendon transfers or fusion procedures for the upper extremity or tenodesis procedures. The limitations there are that we're really, there's an extensive amount of time with post-op immobilization. The biomechanical issues are great. And there is some element of motor retraining. So when we think about spinal cord injury, it includes both upper and lower motor neuron injury. So, if you think about the zone of injury that you can see here, this is sort of a mixed component of injury where we know that the upper motor neuron and the lower motor neuron are injured. However, superior to that segment is a normal supralesional segment, and distal to that are lower motor neurons that are intact. They just don't have, input from descending fibers or cortical input. So in taking this together with nerve transfers, we again think about, okay, well, how can we take something that's redundant and expendable and then rewire it to something that's not working? And so again, we're kind of restoring that volitional control by, again, stealing from another redundant muscle in order to sort of regain that control. So, for example, we can take an elbow flexor, and I'll talk about this nerve transfer, and then give back finger flexion. And again, this obviously relies on cortical plasticity, which is the sort of workhorse behind these nerve transfers working, is that we're relearning. Our brains are literally relearning how to utilize one function for another. It's a little bit different than how we use it in peripheral nerve injury. As we know, in the peripheral nerve, that time is really muscle, right? So the farther we get from the time of injury, the more damage there is to that end organ. In spinal cord injury, the muscle below the injury is sort of kept alive, so to speak, longer because the intact lower motor neuron exists. And so the goal is, can we give that nerve, cortical input again? And again, we're doing that through a functional redundant nerve. Some patients do have mixed injuries, and these patients are not good candidates for this type of procedure. There's a variety of common nerve transfers that folks around the country as well as us are doing. The most important priorities are thinking about restoring active elbow extension. This is very important for patients who are wheelchair bound, and for independence with eating, for example. These are patients that are able to for C5 injury, they sometimes still have preserved elbow flexion, but cannot have elbow extension. So we want to get them back some elbow extension. Restoring pinch is an important component of nerve transfer for spinal cord injury, grasp, and then again, hand intrinsic muscles if we're able to maintain a good balance of that. So these are a variety of some of the different types of reconstructive options for patients with high or mid-level spinal cord injuries. So there's a lot of preoperative considerations for these folks. We think about the timing since their spinal cord injury. In general, just like with peripheral nerve injuries, we want to obviously wait and see what the full potential of their regeneration is. And often we're waiting at least anywhere from 6 to 12 months to kind of see, what kind of function they are spontaneously able to achieve after the insult. And then we really rely, and this is where a multidisciplinary approach really comes into play, because we want to make sure that they continue to have stable joints, their range of motion is good, we're reducing things like spasticity and contracture formation, because even if we have a great nerve transfer option, if they are completely contracted at the site of the joint, we're really not going to have, it's going to limit the benefit of the nerve transfer. So often these patients are in extensive physical therapy and rehab programs, and patient compliance and participation is really critical. There's obviously the social support components and psychological well-being of these patients with spinal cord injuries. That's really important to take into account as well. In terms of pre-op testing, we really rely a lot on our pre-op electrodiagnostic testing. Often that shows us the mixed level of injury. So we're able to see kind of from the EMG, what neural elements are still intact, what may be partially damaged, and what are completely damaged. And we really rely heavily on understanding what our donor nerves are, right? These are the nerves that are going to be those expendable nerves, and we want to make sure that we have redundancy of those nerves. And then we're also looking for, is there any evidence of coexisting peripheral nerve injury that would affect that nerve's ability of being a suitable donor. And then, if again there is this mixed pattern, it's less effective, just because the end organ by that point has also been severely damaged, and it's unlikely that the transfer will work. We are kind of utilizing imaging as an adjunct to look at the muscle quality, how much fatty replacement is present on imaging of the end organ muscle here, and fibrosis. Those findings would suggest that the regeneration to reinnervate that muscle is unlikely to be effective. So one of the common approaches to restore pinch, for example, would be utilizing the brachialis nerve to the AIN. And so the brachialis nerves come off the musculocutaneous nerve. So we're isolating that. And then we're able to dissect out the median nerve. The median nerve, you can see, has a topography that includes a huge sensory component, and then the AIN component that gives you the ability to perform pinch, and then the flexor carpi radialis and palmaris longus components of the nerve, and the pronator component of the nerve. So understanding this topography is important because we are able to perform an internal neurolysis of the median nerve to isolate out the AIN component, and then direct the donor, which in this case is the nerve to the brachialis muscle, and coapt it to a fascicle of the AIN. There's early results in the literature from a variety of these nerve transfers that have reported anywhere from M3 to M4 function returning in many of these patients. Again, these procedures are still very much limited by time, so these patients need to be followed over a long time frame to determine how much improvement they can get. But these are really exciting options for these patients who have very little function to begin with, and these could be important quality of life considerations. So this is an example of a patient that we had, 29-year-old male with a Asia D spinal cord injury at the level of C4. 4. This is a patient who had multiple gunshot wounds. And you can see here his MR demonstrated cord contusion. There's this expansile edema spanning the cervical cord. His spine was managed non-operatively, but ultimately he did have evidence of significant weakness in a variety of muscle distributions, and also demonstrated the typical findings of spinal cord injury, including spasticity, hyperreflexia due to his cord injury. So here we were able to explore the plexus and identify an extraplexal element like the spinal accessory nerve here, again, which is preserved in these cases, and transfer it to a radial nerve triceps branch in order to restore elbow extension, which was very weak in this patient. And then in this case, we also utilized the medial pectoral nerve, which was still functional, and coapted that to the musculocutaneous nerve in order to restore elbow flexion. So to get back elbow flexion and extension. This is another case we just recently did of a 36-year-old with Asia B C5 injury, who was noted to have some improvement over time, but without the ability to extend at the elbow and loss of pinch. And so this was a patient that we took for a direct nerve transfer where we utilized that brachialis branch because he had good elbow flexion. And of course, intraoperatively, we have to confirm that. So these are patients that we directly stimulate the musculocutaneous nerve, identify intraoperative contraction of the biceps before we take a donor. And so here we utilize the musculocutaneous branch, the brachialis branch, and coapt that to the AIN, which we isolate off the median nerve. And again, the goals here are to restore pinch. And in him, we actually had several segments that you can see of the brachialis branches. And so we were able to coapt that directly to the FCR component of the median nerve as well. And then we also, in order to give him back finger extension, which he had significant weakness in, we were able to utilize a supinator branch, which is often preserved in these C5 injuries, and coapt it to the posterior interosseous nerve. So again, we isolate out the supinator branches and make sure that we have redundancy of that, and then utilize those fascicles to reinnervate the PIN, which is important for finger extension. And this is a patient who is also a good candidate for a nerve transfer in which we're utilizing the axillary nerve to the radial nerve to give him back elbow extension. These are folks at C5 who have that some elbow flexion, but really are limited in their daily activities because they lack that elbow extension. Another great option that we have here is utilizing free functioning gracilis muscle transfer. This is a procedure we do with our orthopedic colleagues. So Scott Levin, who's my co-director at the Penn Nerve Center, does these procedures with us where we are utilizing the gracilis muscle with a neurovascular pedicle, including a portion of the obturator nerve, and then utilizing the spinal, bringing it up to the level of the clavicle where it's secured, and then it is sewn into the tendon of the biceps. And again, this is a neurovascular pedicle that is then sewn into the spinal accessory nerve, which becomes the donor nerve here in order to innervate this muscle. And it sort of allows patients to get that function of elbow flexion. And this is a good option in patients who are far out from their injury and have not had any evidence of regeneration of the biceps, and perhaps the biceps at that point is atrophic and scarred to a point that it is not a suitable candidate for direct nerve reinnervation. So just a plug for our nerve center, we want these patients to be able to benefit from the comprehensive interdisciplinary approach we have to treatment of these disorders. I only showed a smattering of some of the traumatic injuries that we manage, but in addition to that, we treat patients with a variety of other nerve conditions, including nerve entrapments, as well as nerve sheath tumors. I think it's really important to highlight that multidisciplinary approach to care for these patients, because these injuries are very complex. There's a variety of possibilities for how to regain a function, and it really requires kind of that multidisciplinary approach to think about what option might be best in relation to, direct nerve repair versus nerve transfers versus tendon transfers or fusion procedures. And so I'm often relying on my colleagues within the orthopedic division or the hand surgeons to really think through some of these different options. And then as I highlighted, it's not just what happens in the operating room. There is a variety of, elements of post-operative care that is provided by our physical therapists, physiatrists who are seeing these patients both pre-op and post-op in order to maximize their post-operative function. So, in summary, time is nerve and muscle, especially as it relates to peripheral nerve injuries. I highlighted already the importance of the multidisciplinary team to think about the different types of options that are available for these patients and how best to maximize their function. As I highlighted, many of the decisions that we make, a lot of these decisions are happening intraoperatively, right? Our first goal is do no harm. And so we're often limited by what we see intraoperatively and what is functioning electrically intraoperatively. So we utilize our intraoperative neuromonitoring to identify functional nerve versus non-functional nerve versus what may or may not be regenerating. And then, obviously we certainly don't want to downgrade any function. And so this is where we want to confirm for at least nerve transfers that there is a redundant nerve that is suitable for taking a donor. And if there isn't, then we abort the surgery. So a lot of these complex decisions are made intraoperatively. And then we always want to think about a backup plan. So, as I mentioned, these nerve reconstructive procedures take time. And we want to think about, okay, well, if the patient doesn't get back elbow flexion, do I have another option? This is an example where, can I think about a Gracilis free muscle transfer for this patient? Well, then maybe we have to remember that let's preserve spinal accessory nerve and not use it as a donor for another function. So we're constantly going back to the drawing board and thinking about the different options. And then, of course, it still takes time to reinnervate muscle. That's one, sort of hurdle that we have yet to sort of work on in nerve surgery. There are a variety of adjuncts that we can use and are using in terms of electrical stimulation to accelerate the time for reinnervation, but it's still a lengthy process. And so this is where it's important to be patient and to, sort of counsel patients accordingly and reassure them and, really push for them to pursue aggressive physical therapy after surgery, because it can be a long time before they regenerate, but they will not, your regenerative nerve will not work well if patients have not been on, keeping their joints active and supple. So it just limits the potential. So it's really, really critical to sort of to maintain that for these patients. And with that, I'll leave you with our contact information at the Penn Nerve Center. I'm happy to answer any questions. I see the question here about how late after injury is nerve reconstruction still possible. So peripheral nerve injuries, it's still debatable, I would say. But in general, after 2 years, the muscle is at a point where it's really not a suitable candidate for receiving neural input. So I would say 2 years is probably the time frame that most peripheral nerve surgeons would really look to other options. It's not that function can't be optimized, it's that nerve sort of reconstruction, probably less good than other procedures like shoulder fusion or even tendon transfers. So again, in order to make that sort of determination and decision, it's helpful to sort of evaluate those patients at a multidisciplinary center. I see another question here about the use of fibrin glue, which contains growth factors. Why not utilize this more often? Yeah, that's a good question. There's certainly, so interestingly, in our pediatric populations, we rely on fibrin glue independently on its own because of the very small diameter of their nerves and the coaptation. So often in those cases, we're just doing fibrin glue alone. The data is interesting. There does not seem to be an improvement in nerve regeneration in humans, certainly with just using fibrin glue versus microsurgical repair. We do worry about not using the micro nerve repair in these patients because the last thing we want is the two ends of those nerves to come apart. Right, the entire procedure is dependent on nerve regeneration across that site of repair, and so the microsurgical repair does sort of allow for that structural integrity of that alignment of nerve fascicle to nerve fascicle. We utilize that fibrin glue because it's a nice sort of adjunct to that microsurgical repair, but I think most folks who do this would agree that the microsurgical component of it is critical. There's another question in the chat. When talking of nerve regeneration on a daily basis, from where to where does that regeneration occur and over what distance to the end of the nerve? Okay, so I apologize if I wasn't clear. Yeah, nerve regeneration, we think of that as from the site of injury to the distal target. So it all depends on which nerve you are talking about. So the more proximal we think about a nerve injury, the more potential targets, right? So this is where an upper trunk injury, for example, at the level of the supraclavicular fossa, is controlling sensation down the side of the arm, it's controlling the biceps muscle, it's controlling the deltoid muscle. There's a lot of end organ targets. So it all depends on which nerve and where in that process the injury is. In contrast, if you had a distal injury, for example, a laceration to a digital sensory nerve, well, then your site of regeneration is right at that site where the nerve is disrupted distally, and then that distance is quite short in terms of its distance to regeneration. So it all depends on where that injury is and what that nerve's normal function is supposed to be. I see another question. What causes sharp intermittent pain after computation at, that might be a typo, I'm assuming coaptation at radial nerve at the elbow level. So we didn't talk about the pain component of nerve injury, but that's a whole topic in and of itself. These neuropathic injuries, including at the level of the plexus or even at the level of the spinal cord and avulsion, can be extremely painful. Often that's what patients are most bothered by, in addition to the weakness. So a variety of different pathologies can exist. that can cause nerve pain. These include things like neuromas in and of themselves versus can there be additional entrapment, ischemia of the nerve, which can exacerbate any pain. So there's not a clear one answer for what can be the etiology of that pain. And this is where some of that pain there we have good solutions for, other forms of it, less good solutions. So often I have these patients evaluated formally by one of my colleagues in pain anesthesia who has expertise in this area. This is particularly important for our spinal cord injury patients, but even for our peripheral nerve injury patients. Often, if there is a focal site of pain related to neuroma formation, for that, we do have very good surgical treatments for it. So those are cases where we then work up sometimes with imaging studies and electrodiagnostic studies, again, to identify the etiology of that pain, and then two, to sort of address that. So lots of different options there that I won't be able to go into detail, but that can definitely be part of the spectrum of nerve injury.
Great. Dr. Early, that's taken us to the top of the hour. Thank you so much for your presentation, and I want to thank everyone for joining us this afternoon. Thank you again, Dr. Early.
Thanks again.